We have a slight change in the schedule. Thomas Leonards is coming, but he's going to be running a little late. So our next speaker is going to be Eberhard Zrenner from Tübingen, Germany, who is going to speak about retinal implant and electrostimulation. Welcome.
So first of all, I would like to thank very much the organizers for the invitation. I'm very glad and happy to be here. I will have two topics. Both are about electricity. Electricity can be used to stimulate neurons and to provide vision. But electricity can also be used to tickle certain cells to release endogenous growth factors to protect cells from further degeneration. This will be part 2 of my lecture. I would like to start with the retina implant, and I also would like to thank to Isabel because she has given a wonderful introduction already into the different types, the subretinal, the epiretinal, and the subchoroidal type of electronic implant to restore vision. We have to be aware that that gene therapy and all the other therapies you learn today are only applicable in patients if patients still have cells, if they still have vision to rescue. You can treat only something which is present. If cells are gone, you can treat them. And the only way presently available to patients to restore vision in case of blindness or light perception only or very low vision, extremely low vision, are retinal electronic implants. There is nothing else. These implants are, there are two types of implants. The Argus II from Second Sight, which you have seen a moment ago, and the Alpha AMS from Retina Implant in Germany. One is epiretinal, the other is subretinal. And I just would like to start with the Alpha AMS, which we have developed in Reutlingen and Tübingen since the most recent 20 years, so to say. And these are both on the market and in Germany and other countries repaid by the public health system. So the target disease is clear, it's retinitis pigmentosa. You have learned this already about epi and subretinal, so I will go into more details into the subretinal approach. How is it working? Essentially, it is a little camera chip, what we are using, like the one you have in your mobile phone from outside, but inside it's very different. It has, but the size is the same, 3 millimeter times 3 millimeter. It has 1,600 pixels. That's not much in comparison to what cameras have, but Argus II have only 60 pixels. And the 1,600 pixel each has a photodiode, like the photocell in the eye. It has an amplifier, which amplifies the light point by point. And it has an electrode, which forwards the amplified current to the bipolar cell layer. Remember, you have these different layers in the cell. All the other layers in retinitis pigmentosa are still functioning pretty well. It's only the photoreceptor layer which is missing function. That's what we are doing. We are replacing the natural photoreceptors with artificial technical photoreceptors. And where is this camera chip? It is in the back of the eye. That's where the photoreceptors had been when they were still functioning. So it's under the retina. The retina is transparent. So the regular picture through the lens, like in a camera, falls onto the back of the eye, goes through the transparent retina, falls on these 1,600 photodiodes, and an electrical image of this picture is produced and forwarded to bipolar cells. So these, just show it here on the picture where they are. These are the bipolar cells here. And then it's processed. So the processing is a natural processing. There is no computer like in other approaches which you have to have in the pocket. There is no camera outside in the face. It's all in the eye. It's moving with the eye. And nothing is to be seen outside except the little coil back behind the ear, like in cochlear implants, where power and signal control is provided. So it's processed and sent through the optic nerve to the brain. And this has a number of advantages. We can utilize all this remaining network. We can use the fixation of the eye, because if you have a camera outside in the goggles, you need to move your head and look what it's doing, whatever the eyes are doing. But normally we are used to find objects where we are looking at. So the fact that the implant is right below the fovea helps us to use this particular pathway from the fovea to the brain to fixate things and to find something. Much easier than with a camera outside. And we can use wiggling eye movements, which we normally have, so to say the microsaccades, which help us to refresh the image. If you have a camera outside, you have to wiggle the head all the time in most patients to refresh the image. If you have the chip in the retina, under the retina, the normal eye movements are helping. Okay, now you have understood how it works, and Dr. Stedt in the afternoon will tell you more about the technology about that. Of course, we need a power supply and other things, which we will see in a moment, like here. So behind the ear there is a transmitter antenna kept with a magnet. Below the skin there is a coil that receives the signals from a little box the patient has in the pocket with batteries, and he can adjust sensitivity and contrast. Like in the old black and white TV, you may remember, football 1954, you have seen how everything was happening in in Switzerland, Bern, sorry. That was not much to see, but it was as exciting as nowadays with HD TV. I think, I wasn't there, I heard it on the radio, nevertheless. Okay, so then from the implanted coil below the skin, there is a cable that runs from behind the ear, under the skin, towards the eye. It enters the eye, a very tiny, thin foil. You know, like in computers, the thin foils with electrical gold wires, printed wires. And it goes into the little camera chip, the AMS, alpha AMS camera chip, which is implanted under the eye. The question is now, how to get it there? That's not the greatest place to put something under the retina. And there were many experiments. Meanwhile, we have operated more than 60 patients. and you see them here. So first a little window is made into the eyeball on the side. You don't see it, it's on the side of the eyeball. Then a little foil, a small foil is advanced through this cut on the side where the muscles are and advanced to the fovea. So it's a tunnel which is made in a way. And this foil protects the retina from damage. And then behind the foil, the implant is advanced. So you see it's elevated a little bit. And behind the foil, behind the protected retina, now you see the chip coming forward until it reaches a place right below the fovea. There it is. And you see the little gold foils in this sketch which provide power and control signals. Each of these dots is a pixel. And the size of the visual field is 15 degrees. 15 degrees is not too much, but you may have had or still have 15 degrees of vision, and that's pretty good to come around, I think, with moving the head and looking. So 15 degrees is not much, but it is absolutely sufficient even to drive a car, actually, because when you go Porsche on the German highway, its things on the side are going so quickly by that your visual field is 15 degrees or even less. That's why highways are always straight, because you may not go easily around corners safely. Okay, that wasn't intended to be discussed. Okay. Now, what did we do so far? We started in 1995, developed the implants, all the preclinical experiments in rats, in pigs, in rabbits, until we really understood how everything is working. We did a pilot study with 11 patients, and there was one critical patient, Mika. He was the first patient where we put the implant under the fovea. Before we always had it in the periphery, that was not sharp enough. And he looked one day at his name, which we had written with chalk on a little black board, 4 centimeter or up to 8 centimeter in height, little white letters on a bar. He was sitting there and saying nothing first. Then he said, "Do you think I am a Formula One driver?" So we asked him, "Why do you think so, that we think that?" He said, Mika Hakkinen, which is a very famous Formula One driver, he writes his name like M-I-K-U, the way you have written it. But my name is M-I-I-K-K-A. So you have made a mistake. So we were very happy about this mistake, because this was really proof he could see and read properly. Imagine our joy in 2010 when we learned that the patient told us that we have made a spelling error. That was great. So we did a few more studies together with other people, Oxford, London, Dresden, Budapest, Hong Kong, Singapore, with 29 patients with the wireless chip, the first generation, we call it, the IMS, that was very much looking like the present version. And it worked pretty well, but it didn't work so long. It was only 9 to 12 months, or even less or more in some patients. That's not enough. If you want to have something implanted, you want to have it longer. But there was problems with cable, there was problems with corrosion. Although patients, for this time they had it, they were pretty happy. I show you what we did with them, and then we developed a new chip. I will tell you at the end, the Alpha AMS, the second generation, which I have tested meanwhile in 15 patients. It's on the market, and that comes at the end. But first of all, what do we do with the patients? We put them in front of a screen, we show them light, we show them gratings, we show a Landolt ring, you know, this C where is open, left, right, up, down. So we learn about visual acuity, we learn about light perception. And then we do daily life activities. We put a plate on the table, a spoon, a knife, a cup. Then we ask the patient, what do you see on the table? Where is it? How many items on the table? What is it? These are the questions. And then we score. And the score is 0 to 5. Actually 5 points, 0 to 4, 0, 1, 2, 3, 4. If patient sees nothing, it's 0. If he has everything correct, it's 4. So what did the patient do? I just tell you the outcome of this early study, which ended in 2013. Roughly 3/4 of the patient had benefit. Some had very good experiences, even reading, telling that there was a Vapiano restaurant, large letters, or something like that, or finding the ADAC, which is a German automobile club, something like that. Well, that were just experiences. Some found it useful, but not to that extent like reading, but still finding an object on a table makes a difference from not finding an object of a table. So you would grab something and you are with the hands in the potato salad. You would like to avoid that, and but it helps. And in a quarter of patients, it was only light source, but also this is helpful. If you see nothing anymore, you are very happy if you see the window or a lamp or a moving car light, something like that. In 8 patients, there was no effect, because some didn't want to learn very much. It's a bit like skiing, you have to train it properly. And in others, in 4 of them, the implant failed. But this is a clinical trial, and we learned enormous things from these 29 patients, which allowed us to create the next generation. Still, these 29, just to abbreviate, 72% reached the primary efficacy endpoint, which was significant improvement of activities of daily living and mobility. And 86 reached a secondary efficacy point, like visual acuity of grating vision. So we were happy. We said, okay, let's go on. Let's provide something which really can be available to patients. That means development, engineering, material sciences, physicists, surgeons, everything had to be improved. I skipped something, and we came out with a new subretinal implant Alpha AMS. So here is the implant, same size with the gold foils. It's implanted the way you know it. It's here with a cable below the skin. And this is a box the patient has. It has 2 knobs for brightness and contrast, and to switch it on and off. That's all. And then we studied this in 15 patients, just published in 2017. Results with a multi-center trial with the subretinal implant Alpha AMS. And I show you a patient from Oxford who, for the very first time when it was switched on, looked at the table with the items, and she was very touched. And so maybe there's a little... Can you give us some audio, please? So she tells us that there is a knife, there is a cup, but you cannot hear it in a moment.
Yeah.
Anything else?
Yeah.
And she looks around and
Yeah.
found the eye cup,
That's the egg cup. That is clear.
the egg cup.
Do you think that's clearer than yesterday
Okay.
when you were looking?
Oh.
And if we look at all these patients together, then we see if the implant is switched on, which are the green bars, in comparison when the implant is switched off, they are doing much better, significantly better with all the screen tasks over this 12-month period, with light perception, with light localization, with seeing the grating acuities, or on the table tasks with finding the items I just showed, or also where the items are. And they are not so good what the items are exactly. They may mix a spoon and a knife, but that is probably not so important. I show you a few movies from the patient at home, because the engineers go home to the patients in the near vision area. So patient looks at a laptop.
Aha. Versuchen Sie es mal zu zeichnen.
Can you like to draw it? So he nicely draws the borders of a square. So that works. Or another implant. It's the same one, sorry. A grayscales. Patient sits in front of grayscales between white and gray and black, and he describes exactly which way it is around, where are the whites and what is in between, because the vision patient have is blurry, of course. It's low vision. It's 20/500. It's not much, but it allows to see a bridge, a car, a scarf, or a head, and some patients even were able to see others smiling, because the teeth are pretty bright contrast against the face, so that helps. Now the movie, again I have problems with the movie. So plate on a table to find. Patient looks around, looks for the various items, and right away
Ja, sehr gut.
sees it. I skip this one. Okay. So now you know the important things you need to know, I think, or which I think you may like to hear about the implant. The question is, when can it help to regain some vision? Clearly, it's related pigmentosa, but light perception or worse, that makes no sense if you still are able to recognize a face or something to do it. If you are an usher patient and you have a hearing aid at one side, it's no problem to put a retina implant on the other side. Reading must have been possible earlier in life. So the brain develops the ability to recognize, and if it's not done in the childhood, then it cannot be developed later on. Still, some retinal inner layer must be there, no macular holes, optic nerve must still be functioning, and of course a proper picture has to go back to the eye, so if you have a trauma of the lens or cataract, it has to be first corrected, and no serious systemic disease like infectious diseases or something like that. And we are very grateful to our people who have worked in this team to develop this in Kiel, in Oxford, Singapore, Budapest, London, Hong Kong, Dresden. If you are interested, you can contact any of these centers or us in Tübingen, Germany. This was the first part. The second part is, what can we do to help the neurons in the eye to survive longer? And if you had looked a moment ago very carefully, you may have seen that over the time, patient became even better a little bit with the power switched off. So this is an effect of a well-known and also described by other groups point, namely that electrically stimulating Müller cells or RPE cells, they do release all kinds of factors that are good for the cells. So secretion of growth factors, they change the BCL2 level, and this has been studied in many investigations in rats, in a number of studies shown here since 2001, and there are nice reviews that say there is a role of electrical stimulation which can help therapy in ophthalmic diseases, published in Graves Archive. This is an example for the specialists. If you take a rat, you stimulate it with alternative current, very tiny current, 300 microampere, for 1 hour. The anti-apoptotic effect of BCL2, not the effect, the anti-apoptotic expression of BCL2 as measured in Western blot goes up within 6 hours, quite a bit, and then in 7 days wears off again. The apoptotic cells are the one who provides the death signals to the cell. They go down. Caspase-3 does nothing, and growth factors, ciliary-derived neurotrophic factor or brain-derived neurotrophic factor, after 1 hour of electrical stimulation of the eye with an electrode, like in the ERG, but not measuring the current, but putting current into the eye, increases the level of growth factors enormously. And there are clinical trials of various kinds for optic nerve diseases, and we also did a clinical trial in weekly, because you saw that it keeps active for 7 days. So we did a weekly stimulation for 30 minutes for 6 weeks in the first study, and we saw that those who received a certain dose of electricity had an increasing visual field, while those who were sham treated, so they didn't get the current, they had a slight decrease, and also lower dose had a decrease. Then we did a second study in 52 RP patients, randomized over 1 year and 3 groups, and it turned out that they had very similar effects, and also especially the electroretinogram, the B wave, and increased and implicit time shortens. And then we did a multicentric study with this device in 105 patients, and again 2 years, 30 minutes a week, we saw in the stimulated eye a significant increase in the best corrected visual acuity. Not in all patients, and this is with many treatments like glaucoma, it lowers the pressure, but it doesn't help all patients. So there is, the device is not shown here, so how does it work? It is called Ocustim. It's like glasses, but instead of lenses, you have a little fine, tiny spider web wire, electrically conducting. You put that onto the eye, the spider web type wire is in the lower lid, and you have a box that provides a current where you put the plug into, and then you sit there for half an hour. You may get a little bit tickling, the eye may be dry a little bit for 1 or 2 days afterwards, so you get some regular wetting drops into the eye. So we learned that it has, in clinical trials, significant improvement. It is safe and well tolerated by patients, and the German health insurance has now acknowledged that it has potential benefit, and we think that's a very important point, that the German healthcare system, it was difficult to get, says, let's do on the expense of the taxpayer in Germany a big trial with 250 people and look on the long-term effect. So we hope that in the next 2-3 years we will be able to get these 250 patients cost-free for the patients into this trial financed by the German healthcare system. So that's where we are. And finally, I would like to show you our new hospital, new clinic, the only one in Germany where a full-fledged research institute with 110 researchers is in the same building with a hospital with 72 beds, and in the same building with the ENT department. So we have a special Usher clinic Wednesdays. Katharina Stinkel, my senior physician, is running it together with Anke Trupic, And if you are interested, I have put here the email where you can write to Katharina if you want to join this special clinic for Usher patients and other rare diseases that affect eye and ear together. Thank you very much for your attention. I was speaking a little bit slowly and overdoing it for 2 minutes, but and if you have questions, I will be there during lunch. Thank you.
Thank you very much, Eberhard.